but it is a very exciting topic because we know that there have been significant advances in the management of patients with hormone receptor positive, HER2 negative advanced breast cancer. So this is really my perspective on how I manage these patients. These are my disclosures. So as you know, in patients with hormone receptor positive, HER2 negative metastatic breast cancer, we really have come a long way. We know that first line endocrine therapy does work in these patients. So we started off by giving tamoxifen that was associated with an approximate 6-month improvement in progression-free survival. We then went on to use aromatase inhibitors that was associated with a progression-free survival of approximately 14 months. We then saw the results of the Falcon trial that randomized patients to receive either an AI or fulvestrant, and now we had a progression-free survival associated with fulvestrant of approximately 17 months. And now in 2020, we have results from combination endocrine therapy trials where you have CDK4/6 inhibitors combined with an aromatase inhibitor in the first line setting where progression-free survival is approximately 28 months, which translates into an approximate 50% reduction in the risk of progression of disease over and above that of using AI alone. Now, this comes from a real world data set in the US, looking at the use of CDK4/6 inhibitors over time. And you can see that the use of chemotherapy has steadily decreased over time, highlighted by the red bars over here. You can see that the use of CDK4/6 inhibitors has steadily increased over time, and that's highlighted by the blue bars here. And interestingly, what you see is endocrine monotherapy has decreased over time, but still a significant proportion of oncologists are still using it. So it's still considered to be, by some, to be a viable option in the first line setting, something that we'll be talking about a little bit later on. So the first question we ask ourselves when you have a patient that's sitting in front of you in the clinic, does endocrine sensitivity in fact matter when planning treatment strategy? And the simple answer to that question is yes, because not all patients will respond the same to endocrine therapy. We know that patients with stage 4 de novo breast cancer have no prior exposure to endocrine therapy. These are your endocrine naive patients. They have the highest response associated with endocrine therapy. Then you have those patients with recurrent breast cancer where they may relapse early within the first 2 years of starting their adjuvant endocrine therapy, and they have a primary resistance to endocrine therapy. And then you have those patients that relapse a little bit later on. They have secondary resistance. And of course, once you've completed your adjuvant endocrine therapy and then you relapse, you have endocrine sensitive disease. And these differences in endocrine sensitivity will influence the outcome of your patient. Now, when you're giving patients multiple lines of endocrine therapy, the added layer of complexity that you observe in your clinic is that biology will change over time. New targets will emerge, resistance eventually develops, and the response to future endocrine therapy is governed by what response a patient has had in the previous line therapy. And it's something to think about when you're trying to give your patient sequential endocrine therapy. Now, in the upfront setting, our CDK4/6 inhibitor is associated with a survival benefit. Well, I thought I would work through a case. This is a 43-year-old lady. She's premenopausal. She presents with a right breast mass and palpable axillary lymph nodes. You can see that the biology of the disease is an ER/PR positive, HER2 negative disease, and a PET CT is quite terrible. She has got extensive liver metastases, extensive bone metastases as well. Her liver function is, however, unremarkable. Her AST and ALT are normal. So some of the issues to think about here is, are you going to give chemotherapy versus combination endocrine therapy? And a knee-jerk reaction when you see a PET CT scan like this is that you want to give chemotherapy. You want to get that rapid response to treatment. However, remember that she's not in visceral crisis. Her liver function is unremarkable at this point. And so we discussed her case in our multidisplay tumor board, and we decided that we would proceed with combination endocrine therapy. Some of the other issues to think about is which endocrine therapy partner are you going to use? And of course, the question that we started off with, is there a survival advantage to using a CDK4/6 inhibitor in the first line setting? Sorry. So using CDK4/6 inhibitors in an endocrine sensitive cohort is associated with a progression-free survival benefit. We've seen the data from Paloma 2, Mona Lisa 2, as well as Monarch 3. And Very similarly designed clinical trials randomizing patients with endocrine sensitive to disease to either an aromatase inhibitor or an aromatase inhibitor plus a CDK4/6 inhibitor. And you can see combination endocrine therapy trumps single agent endocrine monotherapy. But what's more important over here is that you can see in terms of the Kaplan-Meier curves, the separation happens actually quite early, suggesting a very early benefit to using a CDK4/6 inhibitor. Now, remember that patient that I showed you, the PET scan, like I said, was pretty terrible. There's extensive liver metastases in that patient. And as a result, you want a rapid and you want a high response rate. We know from the CLGB 40502 trial, using single agent Taxol is associated with a response rate of about 38%. We know from the exploratory subgroup analysis from Monarch 3 that when you give combination endocrine therapy with abemaciclib plus an aromatase inhibitor, you can get a response rate of up to 57%, which is very similar to, if not better, than using chemotherapy. And you can see the Kaplan-Meier curves here amongst patients with liver metastases. Again, there is a significant benefit to using combination endocrine therapy. Is there a survival benefit to using a combination endocrine therapy? And the simple answer is yes. We have the results of the prospective randomized clinical trials from Mona Lisa 7 and Mona Lisa 3 that randomized patients to receive either ribociclib plus endocrine therapy or endocrine therapy alone. Mona Lisa 7 used tamoxifen or an AI, while Mona Lisa 3 used fulvestrant as the endocrine therapy backbone. But in both of these trials, you can see a 30% reduction in the risk of death from disease. Now, what about some real world data where we have seen an overall survival benefit? And for that, we see data that's been derived from the Flatiron database, about 1,400 patients enrolled in that database that looked at patients who were receiving palbociclib plus letrozole versus letrozole alone. And in terms of an overall survival in this data set, at a median follow-up of 24 months, you can see a very nice separation in the Kaplan-Meier curves with a median survival that's actually not reached when you use combination endocrine therapy, but you can presume it to be at least more than 48 months. And in the control arm of the study, you can see AI is associated with a 40-month overall survival, which is very similar to what's been reported in the clinical trials. But more importantly, what I found that was very important was that there was a very, very early separation in the Kaplan-Meier curve, suggesting that that overall survival benefit is seen very, very early on. And when you look at the hazard ratio of 0.63, that's an approximate 40% reduction in the risk of death from disease when you give combination endocrine therapy. Now, what is the optimal endocrine therapy partner that one should use in the upfront setting? I've shown you trials that have used fulvestrant. I've shown you trials that have used an aromatase inhibitor. And so it really begs the question, which is the best strategy? And that information actually comes from the Parsifal trial that was presented at ASCO this year. It was a phase 2 clinical trial that took patients with endocrine sensitive disease and randomized them to receive either palbociclib plus letrozole or palbociclib plus fulvestrant. And in this particular trial, you can see the Kaplan-Meier curves are very close to each other. Non-inferiority was not proven. Superiority also was not proven. And what you essentially get from this trial is that it's okay to use either letrozole or fulvestrant in the first line setting, although numerically you do see a trend towards benefit with an AI plus palbociclib, something that we usually discuss about in our MDTs. So coming back to this case, she was commenced on palbociclib, a GnRH analog, because she was premenopausal, letrozole, and denosumab. Now, when you want to try and pick and choose the three different CDK4/6 inhibitors that are out there, you have palbociclib, ribociclib, abemaciclib. In my opinion, the efficacy of these three drugs are exactly the same, but the toxicity is very different, and that can help you pick and choose what you're going to use. In terms of neutropenia, palbociclib and ribociclib is associated with more neutropenia. Ribociclib is associated with more AST, ALT elevation. Diarrhea is associated more with the use of abemaciclib. QTC prolongation is restricted to patients who are receiving ribociclib. And we do tend to see a small but significant rate of pulmonary embolism when you use ribociclib or abemaciclib. So when you have that patient in the clinic, you need to see the type of patient that you have in the clinic. Is your patient elderly or a patient with cardiovascular disease? Or does your patient have significant hepatic impairment? Or does your patient have multiple comorbidities? And it's these nuances in terms of trying to profile your patient that will help you in terms of selecting which CDK4/6 inhibitor you're going to use. But in general, palbociclib and ribociclib presents with a predominant bone marrow toxicity, while abemaciclib is associated more with a GI toxicity and less pronounced hematological toxicity. In the upfront setting, are there subgroups you may consider perhaps not giving upfront CDK4/6 inhibitors? Well, we do have the FDA pooled analysis of approximately 4,200 patients from the various clinical trials. And what they essentially tried to look at was different characteristics. And what you see here is, irrespective of the characteristic that you're looking at, the hazard ratios are exactly the same. Your low risk and your high risk groups are benefiting. There's a similar benefit amongst young versus older patients. But the largest benefit that you're actually seeing are amongst patients with stage 4 de novo disease, or those with a DFS of more than 12 months, where you know that those are your very, very endocrine sensitive patients. Now, if that patient that I presented only had bone metastases, one of the discussions that might come up is that should we be using fulvestrant on its own? And the reason why that question comes up is because if you go back to the Falcon trial that randomized patients to an AI versus fulvestrant, amongst patients with no visceral metastases, the use of fulvestrant was associated with a progression-free survival of more than 22 months, really begging the question that perhaps we can get away from using a CDK4/6 inhibitor amongst patients with visceral metastases. Well, at this year at ESMO, we did see the results of the phase 2 FLIPPER trial, which randomized patients to receive either fulvestrant or fulvestrant plus palbociclib. And what you essentially see is that in terms of PFS for the whole cohort, there is definitely an improvement of using combination endocrine therapy versus fulvestrant alone, and this was statistically significant. PFS of 31.8 months when you used combination endocrine therapy. But more importantly, whether you had visceral metastases or there is no visceral metastases, there is an associated benefit from using combination endocrine therapy with very significant PFS values of above 13 months. So again, in that cohort of patients where you think it may not work, using combination endocrine therapy does work. So going back to my patient, she attained a complete response at 6 months, and she's currently still on therapy. So, what do the guidelines essentially tell us? The guidelines tell us that if you have a patient that's in visceral crisis, you should consider chemotherapy. If your patient is not in visceral crisis, that's when you start thinking about using endocrine therapy. It is important that you render your premenopausal women postmenopausal if you're going to get that maximal benefit from using endocrine therapy. And of course, they do recommend that you use CDK4/6 inhibitors upfront at the first line setting, either in combination with an aromatase inhibitor or with fulvestrant, and that is category 1 evidence. But you also have the option of using single agent endocrine therapy with fulvestrant as a category 1 evidence in certain subgroups of patients. And I do have those patients where I will not give a CDK4/6 inhibitor upfront, and those are the patients that we discuss in our MDT. They have certain characteristics that you may want to consider not giving them a CDK4/6 inhibitor upfront because maybe there is a benefit, but the absolute benefit is not that high. Um, and also, you should always remember that you need to have that shared decision making process with your patient, giving them all the results, giving them all the data, and then helping them guide the type of therapy that they're going to receive. Now, in the endocrine resistant cohort, are CDK4/6 inhibitors associated with a survival benefit? Well, in the endocrine resistant cohort, we have three main clinical trials that we need to look at, and these are the clinical trials that we discuss in my clinic. You have the Bolero-2 trial that randomized patients to receive either exemestane or exemestane plus everolimus. You have three CDK4/6 inhibitor trials that randomized patients to receive either fulvestrant or fulvestrant plus a CDK4/6 inhibitor. And then, of course, you have the SOLAR-1 trial that targeted patients with a PIK3CA mutation who have breast cancers with a PIK3CA mutation and randomized them to receive either fulvestrant or fulvestrant plus alpelisib. And across these trials, when you used combination endocrine therapy, there was an approximate 5 to 7 month improvement in progression-free survival. Now, looking specifically at the CDK4/6 inhibitor trials, you can see that in the endocrine resistant cohort, using a CDK4/6 inhibitor is associated with a progression free survival benefit. You see that from Paloma 3, Monarch 2, as well as Mona Lisa 3. But more importantly, what we really want to see is overall survival benefit in that endocrine resistant cohort using CDK4/6 inhibitors. And you can see that from Paloma 3, there's a 6.9-month improvement in overall survival, although it was not statistically significant, but clinically meaningful. And one of the questions that's come up is why were they not able to show a statistical significance? And it's most probably because it was a more heavily pretreated cohort of patients that was enrolled in the Paloma 3 trial. And then, of course, you see an overall survival benefit of about 9.4 months in the Monarch 2 trial. Again, this was statistically significant, and Mona Lisa 3, about a 7.7-month improvement in the overall survival, and this was statistically significant. So, like I said, the reason why we did not see a statistically significant overall survival in Paloma 3 is that Paloma 3 had a more heavily pretreated cohort, and you can see this reflected in the fulvestrant only arm, where you see an overall survival of 28 months versus above 30 months in the Monarch 2 and Mona Lisa 3 trial. But irrespective, you can see that this is a class effect. And across the board from the three trials, the hazard ratio is reflected here, and you can see a 30% reduction in the risk of death from disease. Now, remember, I also showed you the results of the SOLAR-1 trial. It targeted patients who have breast cancers with a PIK3CA mutation present. Patients who were randomized to receive either fulvestrant or fulvestrant plus alpelisib. And you can see in terms of progression-free survival, there was an improvement in progression-free survival from 5.7 months to 11 months. More importantly, at ESMO this year, we saw the overall survival results of the SOLAR-1 trial. And you can see in terms of overall survival, there was a 7.9-month improvement in overall survival when you gave the combination endocrine therapy here. However, this was not statistically significant, but in my mind, very clinically meaningful. And if you looked at that bad cohort of patients that have a high burden of disease and visceral metastases, you can see a 14.4-month improvement in terms of overall survival when you gave combination endocrine therapy. Now, one of the issues that may come up when you're sitting in the clinic is that in the endocrine resistant cohort, if you've tested your patient and that patient has a PIK3CA mutation positive disease and has not received prior CDK4/6 inhibitor, what is it that you're going to use? Are you going to use alpelisib, or are you going to use CDK4/6 inhibitor? Well, I think one should never cross compare trials, but here I've done a little bit of a cross comparison, so please take it with a grain of salt. When you're looking at the overall response rates, you can see alpelisib-based therapy, the overall response rate is about 26%, but if you give CDK4/6 inhibitor, it goes up to about 40%. The median duration of follow-up has been longer for patients who've been enrolled in the CDK4/6 inhibitor trials. And then, of course, in terms of progression-free survival, in the SOLAR-1, progression-free survival was approximately 11 months. We have results from the BYLieve study where patients had been treated prior with CDK4/6 inhibitor, where the PFS has been about 7.3 months. But the largest PFS we've really observed is with CDK4/6 inhibitor, where it's been about 17 months. And when you look at overall survival advantage, you can see with CDK4/6 inhibitor plus fulvestrant, it's been above 40 months. I've shown that to you using a real world data sets as well as the clinical trials. But alpelisib plus fulvestrant is about 39.3 months, and it is not as yet statistically significant, especially since most of these patients did not receive a CDK4/6 inhibitor. I did mention to you the BYLieve study because one of the problems with the SOLAR trial was that most patients had not received a prior CDK4/6 inhibitor. The BYLieve study was a multi-cohort study that looked at giving alpelisib post receiving CDK4/6 inhibitor. Hope Rugo presented this data at ASCO this year. And what you essentially see is that you can, amongst patients who received a CDK4/6 inhibitor plus an AI, who then go on to receive alpelisib plus fulvestrant, you can get a progression-free survival of about 7.3 months. And this is the median progression-free survival. So it does work even post CDK4/6 inhibitor. Now, Let's look at this case. This is a stage 4 de novo patient. She's in her 70s who presented with actually lung metastases at presentation. And we gave her a Arimidex up front without a CDK4/6 inhibitor due to various issues at that time. She did very well for about 2.5 years. And then she presented with extensive liver metastases and extensive bone metastases, and her liver function was actually quite deranged at that time, but she had categorically refused chemotherapy. We decided to give her a combination of fulvestrant plus palbociclib. Within 2 weeks, her liver function actually normalized, her pain got significantly better, and within 2 cycles, you can see a very nice partial response to the treatment, really begging the question, is it time to be more flexible in the definition of visceral crisis? Are there differences between the three CDK4/6 inhibitor? Well, in terms of costs, maybe. In terms of efficacy, in my opinion, absolutely not. You have a PFS of approximately 45% reduction in the risk of progression of disease, and for OS, approximate 30% reduction in the risk of death from disease. In terms of ease of administration, there are differences between the three CDK4/6 inhibitors, with palbo and ribo being given on a 3-week on, 1-week off basis, and abema being given on a continuous dosing twice a day. In terms of toxicity, I showed you there is a difference, and in terms of monitoring, it's reflected by the differences in toxicity. So, yes, there are differences in monitoring. How are we going to integrate some of the other emerging therapies in endocrine resistant patients who have hormone receptor positive HER2 negative disease? Well, we've seen data from the Olympia D as well as EMBRACA trial that if a person has germline BRCA mutation positive disease, giving a PARP inhibitor trumps chemotherapy. And so targeted therapies are advocated here. And then we saw a very interesting results from the plasma match trial that was presented last year at San Antonio that looked at the circulating tumor DNA of patients with hormone receptor positive HER2 negative metastatic breast cancer, testing for various targets. And you can see amongst patients with an ESR1 mutation, there was some benefit to using extended dose fulvestrant. Amongst patients who had acquired a HER2 mutation, there was benefit with combination of neratinib plus fulvestrant. Then we've got some upcoming data looking at capivasertib as a target for patients who've got AKT1 mutations. Now, putting this all together, let's look at the survival benefits. Again, this is cross-trial comparison, but it's just numbers that I've put together. Again, please take it with a grain of salt, but this is just something to try and put everything together. If you decided that you want to use an AI upfront in the first line setting, you get a progression-free survival of approximately 14 months, and then you go on to use combination endocrine therapy with fulvestrant plus a CDK4/6 inhibitor. We know that the overall survival in the endocrine resistant cohort at that point is about 46.7 months. When you combine that with the AI PFS of 14 months, you get an overall survival of approximately 60.7 months. But if you used combination endocrine therapy with a CDK4/6 inhibitor plus an AI upfront, you get a PFS of almost 28 months. And then you go on to use fulvestrant plus or minus alpelisib, where you have to obviously test your patient for that PIK3CA mutation positive disease. But we know from the SOLAR trial that the overall survival is so probably around 40 months. And when you combine that with the PFS of 28 months that you get with the CDK4/6 plus an AI, you're getting now an overall survival of more than 68 months, really suggesting that use your best therapy up front. That's where you're going to get the biggest bang for your buck. So in the last two slides, I've shown this before. This is the algorithm that we tend to follow in patients with no visceral crisis. Use combination endocrine therapy in the first line setting with CDK4/6 plus an AI. In the second line setting, test your patient for that PIK3CA status. If they have mutant disease, give them alpelisib plus fulvestrant. If they're wild type, fulvestrant plus or minus everolimus. Test for those other novel targets in your third line, such as BRCA, HER2, and then later on think about using chemotherapy. If your patient has endocrine resistant disease, ask yourself the question, has your patient received prior CDK4/6 inhibitor? And the answer is yes. It follows the same algorithm that I've shown in the previous slide. But if the patient has not received a prior CDK4/6 inhibitor, you then need to ask yourself the question, does your patient have primary or secondary endocrine resistance? If they have primary endocrine resistance, obviously you need to ask yourself the question, is your patient heavily pretreated with a lot of lines of endocrine endocrine therapy and chemotherapy. And if that is the case, chemotherapy may be the better option. But if they have not received, if they're not heavily pretreated, combination endocrine therapy with a CDK4/6 inhibitor may be the better option. If your patient has secondary endocrine resistance, CDK4/6 inhibitor plus endocrine therapy should be the standard. And then, of course, in your subsequent lines of therapy, that's where you'll be testing for those targets to be able to better improve the prognostic outcome of your patients. So, again, thank you for the invitation and thank you for giving me the opportunity to share my experiences of how I treat patients with hormone receptor positive, HER2 negative, metastatic breast cancer patients.
You know,
And I'd be more than happy to answer any questions.